بسم الله الرحمن الرحيم. Just basic review article يعني basic lecture on the breast calcification. Breast calcifications, what are the breast calcifications? Breast calcifications are calcium deposition which are frequently encountered in the breast. Most are benign and due to cellular secretions and debris, or are reactive calcifications due to trauma or inflammation. This is the breast calcification lexicon. Just this one. So this is the lexicon, breast calcification lexicon. Regarding the appearance of the calcifications, if they are typically benign or suspicious. In the past, we used to say that they are of moderate concern or they are suspicious, but in the new lexicon, we say that it is either suspicious or benign calcifications. The suspicious lesions may be of moderate concern or of intermediate concern. This is the high probability of malignancy when you find fine pleomorphic calcification, fine linear or fine linear branching calcification. Those are the high probability for malignancy. But sometimes we have others of intermediate concern that we term them suspicious calcifications if they are fine pleomorphic, and we have to exclude other causes of calcifications as we will see later. This is the Pirates lexicon of 2003. They used to say that there is benign calcifications, intermediate concern, and high probability of malignancy. But nowadays, just we say that either they are typically benign calcifications, including the skin, the vascular, the popcorn calcification, the rounded or punctate calcification, and the suspicious calcifications, the amorphous type and the coarse heterogeneous type and the fine pleomorphic. These all we can give them Pirates 4B, but the fine linear or fine linear branching we can give them 4C because they have high probability of malignancy. The morphology of calcification is very important. Calcifications are categorized morphologically as to the likelihood of associated malignancy. The Pirates lexicon describes these groups. First, they are typically, this is the old lexicon, typically benign, calcification of intermediate concern, and calcification with high probability. But nowadays, the other 2 and 3, we say them suspicious. Microcalcifications, this is the benign calcifications. Most of them macro and not micro. We will say which the micro and which the macro, how to differentiate. We have the skin calcifications. The skin calcifications are usually bizarre shaped, polygonal. They have lucent center inside, and they have relation to the skin, which sometimes we say it is the tattoo marking to the skin calcification with the skin. Vascular calcifications, the tram line calcifications, coarse dystrophic calcification, or the large rod-shaped calcification that you used to see with the plasma cell mastitis. The rounded punctate calcifications, the eggshell calcification, and the milk of calcium type. These are all with benign entity. This is the indeterminate type or the suspicious Pirate 4B as to the new lexicon. This is the amorphous indistinct types. We found the indistinct shapes, and those are high probability of malignancy, where we found the pleomorphic heterogeneous type. Some of them we term the crush-stoned appearance. Sometimes we say that it is a dot spread in the breast parenchyma. In the comedo type, we find scattered pleomorphic microcalcification, fine linear and branching, and this is the most typical of the malignant calcifications, is the fine linear branching type. Regarding the number of calcifications, the probability of malignancy increases with the increased number of calcification. No exact threshold exists to categorize a cluster of calcification as suspicious, although the risk is greater when 5 or more calcifications are present within 1 centimeter surface area of tissue. But take care when you search about the microcalcification, you better to see them in the two views. And now they say that even 3 microcalcification we could find them suspicious if they have the pleomorphic criteria. Far more important is the evaluation of the morphology of the individual calcifications. Any number of suspicious calcification required biopsy, and usually biopsy, if we not see the microcalcification, usually not seen, the suspicious, of course, are not seen by ultrasound, so we better do it with the stereotactic biopsy. Conversely, a cluster of more than 5 calcifications with characteristic benign features could be monitored mammographically to see if they will change or not. And this is again figure showing the appearance of different types of calcifications. This is the typically benign appearance. This is the skin calcifications, the vascular calcifications, the coarse dystrophic calcification, the rod-like calcifications casting the duct as in cases of plasma cell mastitis, and the rounded calcification punctate. We always describe those on mammogram as punctate calcifications. This is rim calcification, which is usually seen in oil cyst. This is dystrophic calcifications, as in fibroadenoma, for example. Milk of calcium type and calcification in the sutures or the appearance of the suture with calcific foci. This is the suspicious morphology. This is the amorphous type. This is the coarse heterogeneous type, fine pleomorphic and fine linear branching. Then regarding the distribution, again we are talking about the morphology of calcification, then the number of calcifications, and then the distribution of calcification. Distribution of calcification either diffuse, scattered, or regional, or grouped. We used to say cluster, but nowadays we say grouped microcalcification, linear calcification, and segmental calcification. And these are their shapes. This is the diffuse, scattered macro and microcalcification. They are rod shaped and some of them punctate, and this is the typical of secretory type of calcification. These are the regional. They take a region but not segmental like that area. You know, when you take a segment of the breast, it comes from the nipple to the lobules, so this is segmental. And this is the regional type, and this is the grouped clustered microcalcifications, and this is the linear type of microcalcification. So if you see that figure, you will see how to group the type of calcification you see, either diffuse, regional, segmental, grouped, or linear type. This is the linear branching type of microcalcification. Regarding the size, micro or macro, calcification as small as 0.2 to 0.3 millimeter can be visible mammographically with the aids of magnification and compression, and nowadays with the aid of the artificial intelligence and the computer assisted. In general, small calcifications are more suspicious for malignancy. Breast carcinoma usually produce calcifications less than 0.5 millimeter in diameter, while the microcalcification are those more than 0.5 millimeter. They are with the more benign type of calcifications with calcified fibroadenoma, which is most common, which is the involuted type of fibroadenoma that we give it by REDS2, cyst showing curvy linear calcification. Calcified suture material will be dense curvy linear appearance. Cavernous hemangioma with coarse punctate calcification and lobulated soft tissue mass. Post-surgical scar, punctate coarse stromal calcification, which is common with fat necrosis. And renal failure, which is a type of secondary hyperpara causing extensive stromal calcifications, and we will see picture for it later on. This is microcalcifications. This is fibroadenoma, the typical popcorn. This is the typical popcorn calcification with soft tissue mass, sometimes associated with soft tissue mass, and sometimes the fibroadenoma as a whole will be calcified like this. When starting the fibroadenoma to calcify, they calcify from the peripheral to the center if it is large calcifications, and you find the soft tissue fibroadenoma. You can see the soft tissue well circumscribed lesions associated with this calcification, and this is also with involuted fibroadenomas. This is the typical popcorn, and this is the appearance of microcalcifications, and this is another case showing multiple variable sized well circumscribed masses, and two of them showing the coarse calcification of involuted fibroadenoma. Sometimes also in the involuted fibroadenoma it appears rather irregular in shape due to hyalinized appearance of the fibroadenoma, and the density of the fibroadenoma becomes lower than the parenchyma. So this is involuted fibroadenoma also. Less common to find an irregular or curvilinear egg shell calcification in the periphery of the lesion. Popcorn calcification of fibroadenoma. Then we came to the eggshell or rim calcification. This is the egg, what we termed the eggshell calcification or rim calcification. They are very thin benign calcifications that appear as calcium deposited on the surface of a sphere. It is a calcification deposited on the surface of a sphere, usually under 1 millimeter in thickness. Although fat necrosis can produce these thin deposits of calcification, but can occur in the wall of cysts, and we term them rim calcification. But the most common to cause rim calcification is the fat necrosis. And then we came to another type of benign looking calcification. These are the vascular calcifications, parallel tracks or linear calcifications that are clearly associated with tubular structure. It is tram-like calcification. This is the appearance of vascular calcification. Vascular calcification, we see them mainly vascular calcifications in the old age, maybe after 70, but sometimes if the patient is diabetic, we saw them earlier than that. We found in 50 years old patient, we can find this vascular calcification if she's diabetic. And there is studies done to correlate between the vascular calcifications in the vessels of the breast and those with the coronary calcification. Is it correlated or not? This is another rare calcifications, like calcification in a worm, Dracunculus resulting infection, Dracunculus medianis worm, were causing calcification, although it's very rare, may be seen in the endemic areas just. This is the appearance of worm-like calcifications. Microcalcifications, the size is less than 0.5 millimeter. The shape, single most important feature to see the shape of these calcifications, if they are pleomorphic or punctate, or what is the appearance. In number, the volume, significant grouping of calcification in 1 centimeter surface area, associated soft tissue density increase the probability of being invasive. Examples of benign and malignant calcifications. This is benign calcification. Usually the benign calcification, as we say before, they are punctate. They have a lucent center inside. Usually having a lucent center inside. This is with benign type of calcification. While in the malignant type, they are less dense. Although we may have benign and malignant calcifications at the same time. And these calcifications are linear branching and they are pleomorphic in shape. So we have to take care. There may be benign and malignant calcification in the same film. Another case, this calcification, here this is clustered calcification, not here. This is benign calcifications, secretory benign calcifications. We usually see them, we use to say that they are cases of plasma cell mastitis, but they are secretory calcifications. And here we have the pleomorphic type clustered microcalcification associated with a soft tissue density, so they are suspicious. So again, how to compare? This is benign type of calcification and this is malignant type of calcification. This is clustered, also clustered microcalcific focus, but with no associated soft tissue density. They are pleomorphic in shape, of different shapes and sizes. They are of low density, so they are maybe missed during the exam. Then the microcalcification, we have other classification of the microcalcification. They may be arising from the parenchyma of the breast or otherwise. Parenchymal calcification may be ductal in origin, ductal calcification, which is a marker for the DICS. Ductal carcinoma in situ, high-grade comedo type. Usually it is high-grade comedo type calcification. They are calcification in the necrotic material within the duct and not in the tumor itself. They appear linear, fragmented, branching, irregular, casting type of calcification. They are casting the ducts. This type of calcification, this is the ductal carcinoma in situ. The high-grade type, which is called the comedo type. This type, what is the distribution in this case? It is segmental type of calcification associated with soft tissue mass, and there is associated architectural distortion. They are pleomorphic, different sizes and shapes. Again, these are pleomorphic of different sizes and shapes. Some of them are linear branching, so they are high-grade DICS. DCIS, this is the comedo type of calcification. This is another type. Here we can say that it is a regional type of calcification. It takes a large region of the breast with powderish-like appearance. It looks like a powder. It is a powderish-like appearance. This is another type of malignant microcalcification, and I think that associated also with increased soft tissue density. And here will be the role of different imaging modalities like contrast mammography to see the extent and the enhancement of this lesion. Intermediate or low-grade cribriform type of calcification, it appears as single or multiple clusters of coarse granular type or pleomorphic particles like fragments of crushed stone or broken needle tips. Sometimes we can describe them as crushed stone or broken needle tips. Predominantly low-grade, they are fine particles having the powderish appearance that we have seen in the previous film. This is the powderish appearance. And from the imaging, we can see if this high-grade correlated with high-grade type of malignancy or low-grade type. The presence of associated soft tissue density, it will be with invasive rather than ductal carcinoma in situ. So we have fine pleomorphic, fine linear, and fine linear branching. And this is another case of segmental distribution of comedo type carcinoma, and we have here an associated soft tissue mass, and we have here retroareolar lesion also present. So all these sector have malignant spread, and so in these cases also we can do contrast mammography to see the lesion well. Microcalcifications to guide the removal of microcalcification, we can do a wire, we can do a stereotactic biopsy, but it's not out of the scope of this lecture. This is secretory calcifications. We used to term it plasma cell mastitis and associated with ductictasia and fibroadenosis. Calcification may occur in the duct wall, in the duct lumen or periductal. But this calcification, either it occurs in the lumen or periductal, and sometimes when we do ultrasound, we will find spotty calcifications within the duct itself. We found these calcifications inside the duct to be sure that it's secretory calcifications. Bilateral, usually bilateral and usually in the anterior third of the breast, linear tubular dense with well-defined borders. And sometimes you find lucent center like this we have here. This large one have a lucent center inside because it occurs in the wall of the duct, as we see, more than in the cavity. And this is another case of secretory changes in the breast with rod-like tubular dense calcifications. Lobular calcification, this is the ductal. Regarding the lobular calcifications, mostly they are benign. Microcystic changes may occur in the end of the lobules. This is the duct, and this is the lobules, terminal ductal lobular unit. Increase in the number and size of the acini, multiple rounded discrete particles of similar density. These are the scattered punctate calcifications. These are the scattered punctate calcifications. They are widely distributed and may be arranged as rounded clusters. So these are the secretory punctate calcifications. Then, so this is another type of benign looking calcifications, and if you know this is the lobular type of calcifications. This is scattered, but this is a magnified part showing they are well defined. Macro and micro. They are macro and micro types of calcifications scattered in both breasts, usually in patients causing fibroadenosis. But if you have scattered calcifications but you found area of them suspicious, you can do other imaging investigations. The problem is with this type of adenosis, this is the sclerosing adenosis. In the sclerosing adenosis, the appearance of the ductal lobular unit will be like that. Sclerosing adenosis will be proliferation of the fibrous tissue around the lobules. Calcification is distorted, pleomorphic, and irregular. Calcification is in distorted lobules, they are pleomorphic and irregular, and so usually they give suspicion of malignancy, and there will be associated architectural distortion, makes them more suspicious. This is the sclerosing adenosis. And this is the lobular changes also, which is called the milk of calcium. If you have look near, you will find that it look that the cup-like, because the milk of calcium in the lobules, it is in the dependent part and giving these curvilinear structures. So they are benign sedimented calcifications in macro and or microcysts. On the craniocaudal view, they appear as fuzzy rounded or amorphous calcification, and on the lateral view, they may appear as semilinear crescent-shaped teacup calcification. This is the microcystic changes of milk of calcium. Then we have calcification. So calcification inside the glandular tissue, either ductal or lobular calcifications. We have calcifications located outside the glandular tissue. And this is the most important of them are the skin calcification. They may mimic cluster of microcalcification within the breast tissue, and they are present in fixed position within the dermal layer in most cases. They present in a fixed position within the dermal layer. Like in this case, we have some clues for the dermal microcalcifications, or macro or micro. We have a clues. What are the clues for dermal calcification? Skin calcifications are most commonly seen along the inframammary fold parasternally, and the axilla and areola and retroareolar. So we will find them in the inframammary fold here, in the inframammary fold, rising to the axilla, and sometimes retroareolar. They have lucent centers They have lucent centers. They are polygonal in shape and linear orientation because they are related to the skin. So they have linear orientation. So these are the clues for dermal calcification, and this is a case of dermatomyositis showing dermal calcification. Another skin calcifications field dermatomyositis. Dermatomyositis may cause extensive bizarre shaped calcification like that. Of course, by ultrasound we can see that it is related to the skin more than mammo also. And of course, the history of the patient. These patients, they know they have dermatomyositis, so always ask the patient when you found this bizarre type of calcification. Then we have another type of systemic cause of calcification is the secondary hyperpara, those with renal failure, extensive diffuse or any other cause, extensive diffuse vascular calcification, and diffuse subcutaneous calcification also. Here we have diffuse vascular calcifications, we have subcutaneous calcifications, and we have also parenchymal calcification. So this is a case of secondary hyperpara. We have also calcification that may occur intradermal, like steatostoma multiplex. We have, and this is very, very suspicious for malignancy, except if we try to see that it is related to the skin or not. This is punctate calcifications, 2 millimeter to 2 centimeter, and they may cause, but if you see the lesion magnified, you find that there is oil cyst, and this is calcification in the wall of this cyst. So take care. Pseudoxanthoma elasticum, also we have multiple irregular fine calcifications, but the patient known to be have something related to the skin. Multiple irregular fine calcifications. So take care of the skin calcification. Another cause of calcifications are the fat necrosis. They are not in the parenchyma, they are some sort of dystrophic calcification. Liponecrosis macrocystica, coarse curvilinear calcification with radiolucent center, but sometimes we have small calcifications, 1 to 4 millimeter with lucent centers. So this is this type, this is, but we have here a scar and we have an oil cyst. So this is not a suspicious calcification. So liponecrosis may cause macrocalcific foci and may cause microcalcific foci similar to the malignancy. So always we can do, if it is a case of post-surgical, we can do MRI to see if there is enhancing lesions or not, and follow up, and we get the previous examinations in order to see that it is a type of fat necrosis or not. This is the typical oil cysts. This is the typical calcified rim calcification. This is the typical rim calcification of multiple oil cysts, either due to trauma or either to surgery, according to the patient history. Calcifications are the most important markers of new or recurrent breast carcinoma. Breast calcifications arise within areas of fat necrosis and stromal fibrosis. Pleomorphic or glandular microcalcification are suggestive of recurrent or residual malignancy, and this is most important in the post-operative breast. Is it recurrence with calcification, or it is some sort of either dystrophic calcification or fat necrosis? This is another case of radiolucent oil cyst with thin arc of calcification around the radiolucent cyst, and by ultrasound this is the calcification which cause shadow outside the cyst. There is posterior shadowing outside the cyst, and the oil cyst in ultrasound may cause shadowing even if it is not, when it is not calcified, because the oil cannot pass the sound waves very well, زي cyst of watery secretions which can cause posterior enhancement and not posterior shadowing. Another case, this is bilateral oil cysts with calcified margins. And this is the sutures of previous operation. And here we have scattered foci, streaks, plaques, needle-like, smooth or rounded calcifications. All that can be seen within the scar site. Here it is a scar with lucent center and calcific foci within the lucent center, indicating more that it is fat necrosis rather than it is recurrence. Residual mass or calcification. Here it is away from the scar site, and this is faint calcifications, vague mass near the surgical site. Of course, this is in need of further assessment either by biopsy, MRI examination to detect if it's associated enhancing mass or not. So this case is suspicious, need further workout. Dystrophic calcifications. What are dystrophic calcifications? These are coarse irregular calcifications larger than 0.5 millimeter, and they have a lucent center. They are seen in irradiated breast or following trauma. They develop 3 to 5 years after treatment in 30% of women. So we can have this dystrophic calcification not just immediately after surgery or after radiotherapy. It is in range of 3 to 5 years after treatment, and it can occur in 30% of irradiated women or after surgical removal of the lesions. Also described as fat necrosis, it is important to differentiate them from recurrent malignant lesion also. Digital mammography, of course, in the digital mammography, the calcifications, some of the images I put, it was long ago from our old machine. It's not digital, but we can see the calcifications by this machine also. And then now there is the dedicated computer-assisted diagnosis and the telemammography and archiving. All these are better resolution, and we can get the better assessment of the microcalcification like in these two cases. And then the computer diagnosis or the artificial intelligence, which can detect subtle changes of cancer. And but I want from this lecture not to go to the new advancing modalities and the computer-aided lesions, but I want you to detect from the conventional images. How can you detect the microcalcification? By precise assessment of the mammographic image. This is the computer-aided diagnosis. I think this is just a brief for those who are still beginning to see about the breast. This is diffuse calcification. It's malignant bizarre-shaped calcification, regional type. And here also, this is a calcification dermal related to the skin, and this is what we call the tattoo sign. It's related to the skin. This is 30 years old female developing hard mass at the site of the incision after reduction mammoplasty, so it's not a malignant case. And this is the typical appearance of fat necrosis. It is related to the oil cyst, so it is not suspicious. And the patient, she has no suspicion before, and so just for follow-up, and on follow-up it was the same appearance. So if you can give for this case PIRAT-3 for follow-up, it's okay, because you have no history. It is related to the scar site and the fat necrosis. In reduction mammoplasty, we have a high incidence of fat necrosis because we remove a large amount of tissue. So take care. And this was her ultrasound appearance, and this is the appearance of the oil cyst with associated calcification surrounding and in the wall of the oil cyst. And here there is enough of echogenic, which is another spectrum of the appearance of the oil cyst in the ultrasound. So this is a case of fat necrosis. This is another case. It's markedly distorted contour of the breast. It's post-operative. There is a skin dimpling, and this is it's the scar showing fat, entrapped fat inside, or fat necrosis with dystrophic calcification and sutures. So this is another case of fat necrosis. But usually, in these cases, you don't put it pyrette from the start. Just you can do ultrasound to assess if there is no soft tissue masses within, or another or newly developed mass, either recurrent or newly developed mass. So do ultrasound with Doppler in order to exclude the presence of mass. If you find suspicious mass, then we will go to MRI to see the extent of this recurrent lesion. This is another case when you find the breast smaller than the other, when you find the skin thickened, when you find there is axillary dissection. This is a case of conservative breast surgery. And here we have a lesion which is with lucent center, and this is the clips inside. So again, this is a case of fat necrosis. But what about this case? No, this is different. We have here a focal asymmetry in the left upper outer quadrant with distortion, and then we have the clustered pleomorphic microcalcifications. These are clustered pleomorphic microcalcifications. They are associated with soft tissue mass and architectural distortion. So I think this case we can just take a biopsy by ultrasound from them. And this is the lesion. So they are suspicious grouped microcalcification. They are 4B or 4C because there is associated mass. Regarding ultrasound, we will see after how to see calcification. Did we see calcification ultrasound? Of course, if it is associated with within a mass, we can see calcification with ultrasound, but the fewly scattered or clustered calcifications cannot be detected. Sometimes the secretory calcifications can be seen well on ultrasound because in the wall of the anechoic ducts, so we can see them by ultrasound. Thank you for this brief lecture on the breast calcifications. I hope it will help you. Thank you.